This show is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. The content on this show is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they have, and they should seek the assistance of their healthcare professionals for any such condition.
This is Rooted in Healing with Dr. Beth Claxton, exploring the science of functional medicine and the power of healing from within. Breathe in, breathe out. And now your host, Dr. Beth Claxton.
Good morning, Dr. Beth Claxton. I'm here with you on Rooted in Healing for another, I think it's going to be a wonderful episode. I want to start this episode with a quote that we're going to unravel in the interview. This is a quote from the 1950s. It's actually his teachings. Jiddu Krishnamurti said, "It's no measure of health to be well adjusted to a profoundly sick society." And what we see now is decreasing fertility rates, decreasing birth rate, decreasing sperm production in men. And what's happening? Like, we are becoming a sicker and sicker society. And yet I talk to people that say, "Oh, I'm doing everything in moderation. Everything in moderation's okay." But doing things in moderation when everyone around you is profoundly sick is probably following not a good path. So our guests today are Emily Rydbom and Leslie Stone, which are a mother-daughter team out of Oregon. They're functional medicine. Leslie and her husband teach with the Institute for Functional Medicine. And Emily, their daughter, grew up at home around the dinner table in the middle of functional medicine conversations. So she, like my daughters, had no choice but to hear all of the information and the conversations around root cause medicine. And she went into nutrition, and she and her mother are now impacting society in a very powerful way. In their clinic in Oregon, they started a individualized approach to pregnancy care. And what they've seen is, as you'll hear in the interview, profound changes in the outcomes, way, way off of the national average in birth outcomes, delivery dates, C-section rates, and extrapolating out from that, maternal perimenopause. So taking that mother, if she is treated with a functional medicine approach during her pregnancy and adopts that type of lifestyle approach to the rest of her life, we can see changes in her perimenopause, changes in her menopausal transition, and changes down the road. Not only there, but changes epigenetically, so influencing her baby's genes, which genes turn on, which genes turn off, which genes are expressed more robustly in that baby's early life, in that baby's life as it grows up, so that that baby can have a healthier life, healthier reproductive life, and healthier later life. And in turn, by turning on its own, so mother's offspring healthier, their offspring healthier. So we're turning back this disease in our society, one person at a time, through a functional medicine approach that's starting in pregnancy. We also get into the conversation of the fact that 50% of pregnancies are not intended. So 50% are unplanned. What could happen, what does happen when 50% of the time the whole family comes, the mother and the father come for pre-pregnancy care? influencing the sperm and the quality and the genetic makeup of what the father is contributing to the pregnancy has profound impact on the pregnancy itself and the baby's life, its outcomes as it grows up. So the father actually does have the health of the father and the quality of his sperm and which genes are turned on and off and expressed in the sperm have a profound impact on the quality of everything afterwards. So where we often have referred to men as simply the sperm donor men, it's important to understand that you are not just this. You are contributing a lot, and you could contribute more by taking really good care of yourself. We dive into the root cause, the soil, the quality of our soil and how we're growing our food. We also dip into the stress aspect and how empowered women can be in their pregnancy to control their own stress response, to take a moment and listen to something that helps their body relax and improve placental blood flow that improves the health of the baby and the outcome of the pregnancy. So when there are times of stress, the mother knows that she can and she has the power to respond in a different way. So this is an incredibly empowering interview for anyone who is pregnant, anyone who has children, anyone who has children who are getting married, planning to have a family. Please send this to them, this interview to them, so they can listen, so they can learn, and we can change the outcomes of pregnancy. We can change the fertility rate, we can change birth rates, we can change sperm counts, and help turn around this disease and imbalance that's happening in our society right now. So with that, I'd like to move to this commercial, and we'll be right back with Emily Rydbom and Leslie Stone for our interview on Rooted in Healing. Thanks so much.
And now, more Rooted in Healing with Dr. Beth Claxton.
Hi, and welcome back to Rooted in Healing. I'm Dr. Beth Claxton. Today is a very exciting interview for me. It's a conversation that I've wanted to have for several years since I learned about the work of Emily Rydbom and Leslie Stone. Emily is a board-certified holistic nutritionist, certified nutritional professional, and a candidate for Masters of Digital Health. She is an entrepreneur, published researcher, and international educator who's been on the leading edge of applied perinatal personalized nutrition since 2011. She's most widely known for her groundbreaking work in the improvement of transgenerational health as the co-founder and CEO of Grow Baby Health, a clinically proven integrated perinatal nutrition program that durably decreases the risk of poor birth outcomes and maternal vulnerabilities. The founder of Grow Baby Life Project and co-founder of Grow Health, a digital health scaling platform for personalized perinatal care. A key focus of her work, advocacy, and research over the last decade has been empowering women and couples during the preconception, pregnancy, and postnatal time period, and teaching families about healthy nutrition and lifestyle balance from 6 months through 5 years and beyond. She's the co-creator of a first-of-its-kind genetic test that screens for genes associated with maternal health and fetal health outcomes, emphasizing the modifiable aspects of host environment personalized genomics. She works as a clinical advisor for several well-known nutraceutical companies. Emily was a co-investigator on several Grow Baby studies over the past 14 years and is nutritional lead on the ROOT study, a 500 mother-baby dyad study in North Carolina in partnership with a major Medicaid payer, a major hospital system, and a key clinical OBGYN team. Leslie is a board-certified family practice obstetrician with a fellowship in surgical obstetrics. She's a published researcher and international educator. Since 2011, in clinical practice, Leslie and Emily have been applying Grow Baby in a 50% Medicaid OB setting, where their unique pregnancy care model shows a decade-long track record of better pregnancy and birth outcomes. The Grow Baby model has been applied in 4 different states and 4 different delivery systems with continued success. She is the co-creator of a first-of-its-kind genetic test with Emily, and she co-developed prenatal formulations with one currently available in North America. Leslie's been the principal investigator on multiple Grow Baby studies and is currently to be principal investigator on the ROOT study. She has delivered well over 5,000 babies in her career since 1984 and worked with Dr. Michael Stone, her spouse, in a clinical setting from 1984 to 2022. And Leslie continues to cover OB call at the local hospital several days a month. Welcome, Leslie and Emily.
Thank you. Thank you very much, Beth.
So happy to have you here.
We're happy to be here.
I'm really curious about how you got started doing this work and how you got traction, because as an obstetrician, it's really hard. It feels daunting to make an impact when you see it as so needed.
I'll start off with that one, just simply because my age gives me the perspective, perhaps. And so I felt like I had excellent care, I should say excellent training in obstetrics and in family practice, and that combination gave me and the people who work with me a cradle-to-grave perspective on our health or lack of health in general, not just the pregnancy time period. So here we go, fast forward into being a practicing physician, practicing obstetrician, and doing really what I would believe is excellent standard of care medicine and delivering wonderful mothers and babies who are doing all the right things and still not having any changes in the risk, in the outcomes, these adverse outcomes that just keep continuing to rise.
Can you talk about... Excuse me, Leslie, can you talk specifically what were those outcomes?
So the ones that appear to be key, not only for maternal health, but also for the baby, the neonate, and then that neonate as an adult, turns out to be high blood pressure is the first one. The one that's particularly a bother and can lead to all sorts of other adverse outcomes is pregnancy-induced hypertension or preeclampsia. And it increases risk for another one of those that predicts risk, and that is preterm birth. We're more likely to deliver a preterm baby. And there might be some growth issues, and they might be too small for the age at which they are delivered, for the gestational age for which they're delivered. Other ones are gestational diabetes. People, while they're pregnant, become diabetic. It's a little bit of a setup just because of the way our physiology changes during pregnancy. But nonetheless, if that person develops it, then their baby is more likely to have some adverse outcomes, larger for gestational age, and those predict some difficulties down the way. So if down the way for their future resilience, I should say. So those are the key pieces that we look at. We look at pregnancy-induced hypertension cluster, hypertensive disorders of pregnancy. We look at gestational diabetes. We look at, along with that, weight gain. And then we look at too small of a baby, too large of a baby, and a baby born too early. Mm-hmm. So those ones, I think that my allopathic background taught me that there wasn't a whole lot I could do about that. But, we just weren't getting any better. And so our outcomes were not getting any better. And so we started picking away at, what is the functional medicine way of thinking, the systems, dissecting down to root cause and starting to personalize. We became immersed in that concept and started at first picking away small individual micronutrients. Well, and we found that, like magnesium and vitamin C, some stuff that had some data behind it, we found that didn't seem to make any difference either. So we went, okay, well, maybe what we really need to do is look at the whole person and tease apart their individual systems' root causes. And then even if we can't get every single one dialed in, maybe the push and pull, the compensation we can build, we can optimize the health and the resilience of that mother and thus the outcomes that baby experiences. And lo and behold, as soon as we put together micronutriture, small, meaning the small little tiny nutrients that we take in, and we started putting together the macronutrients, how much protein, how much carbohydrate, how much fat, and then we added in simultaneously, it looks like there's some genetic, small, tiny, frequent gene variants that also tell us that maybe there's going to be a risk for some micronutrient deficiencies. So we managed those. We started looking at environmental exposures, including stress and stress response, and we started managing those, figuring out where people were vulnerable, where they were strong and resilient, and then we optimized those pieces as best as the mother could do. The first place was, of course, it was letting her realize that there's the most empowering pieces. We let them know there's something you can do about this. Because I think that many women at the beginning of this project thought, there's nothing, I'm just stuck, there's nothing I can do. Well, we put this all together, and kaboom, all of our adverse rates dropped, plummeted to far below, statistically significantly below the standard of care, which is good and necessary, but it's just not enough. It's basically two different ways of looking at things. One is interventional. The other one is preventive. It's looking at root cause and personalization, and that's what's made all the difference.
Mm-hmm. Beautiful. And then how did Emily come in and find her way into this puzzle?
So Emily has been immersed in this concept of systems or functional medicine at the dinner table with Michael Stone and spouse from the time that these were concepts that could be discussed. So, preteen, right? And her interest in nutrition blossomed and grew. And as it turns out, just as we were discovering that this concept was one of systems and root cause, Emily decided to go into nutrition. And as a result, she listened to this story, a very good complex thinker, Emily is, and she took all these pieces and figured out how to put them into a program that was doable, that could be taught, and a way to personalize, take the data that's given her and personalize it to the individual in a doable, delicious sort of a way. And so she has created these pieces to make them reproducible and scalable. So that's how she came into this being.
And I have a question, Emily. I have 2 young adult daughters who definitely heard all of the nutritional lifestyle dinner table discussions. Was there ever anything else that you felt drawn to do with your life, or was this a very natural progression?
Well, I think, I always say in another life I would have been a chef. So I think my interest in food and in the communion around food and how powerful food was as a connector and as a common language, so to speak, has always been kind of front of mind. And but I realized that what I loved about nutrition and what I loved about food and what I loved about combinations of flavors and colors and textures was ultimately, as a chef, I knew I was never going to be able to share that experience with the folks I was feeding, which I recognized early. That was the powerful part. It was the connection to and the reason, and it was the community building around what food was. And so I shifted tact a bit and knew very much that I didn't want to be a doctor, mostly because I was watching my two parents, who are incredibly compassionate, giving, loving humans, I think, like all providers are. I mean, I think there's big hearts in all of the providers walking around the world right now, but that this system didn't allow them to have the time to connect in what I consider to be a good enough way for me. I mean, because food is, if not anything, founded in an emotional experience and an emotional connection. Oftentimes, we don't always eat cookies because we're craving something that's sugary. Sometimes we eat cookies because we remember making cookies with our grandma, who was so important in our lives, and now she's gone. And so cookies are a way for us to connect back to a feeling, right, and to an emotion. And I think it's important to remember, above all else, food is meant to be emotional. I mean, the plants that we consume hold neurotransmitters in their species, in their phytochemistry, that elicit feelings that are meant to make us be emotional, happy, right?
Right.
Sad. And I think for me, that conversation required more time. And so I discovered through nutrition that the system allowed me to be a nutritionist, and at least in, this is getting a little into the weeds, but at least in the state of Oregon, allowed me to do so under the delegated service model, which allowed both Dr. Leslie and Michael Stone to delegate nutrition services, just as though they were being, they were able to be reimbursed at the same level in an insurance-based reimbursement clinical practice, and didn't require cash. And so it was actually a lot of the ingenuity of both Dr. Stone's to say, let's figure out how to infuse nutrition in, get it covered by insurance so it's more accessible to people. Because at the end of the day, I think this conversation for me has always hindered around flexibility and adaptability to the person that you're speaking to. And so that's a long-winded answer to say I used to want to be a chef, but being a nutritionist is a very, very wonderful alternative.
Yeah, and I was also thinking about the proximity of the hippocampus in the brain, that it's the beginning of memory is right next to the olfactory or the smell center.
That's
and so,
right.
Yeah,
that's right.
It's all so connected. Okay, so let's talk about our preterm birth rates now and other adverse outcomes, like the ones that Leslie brought up, and how and that they're getting worse, not better. And in my practice, what I'm seeing in my locums practice, the filling in, that I've observed through my career, maternal weight has increased to the point that there are mothers that are so large now that they need to be transported for an operating room table that can hold them in case they need a C-section. The rates of diabetes, preeclampsia, and women are coming back with something called postpartum preeclampsia, which I had never seen in my career until maybe 10 to 15 years ago, and then it started popping up, and now it's incredibly common. So I'd love to hear what you have to say about what's happening.
I'll jump in.
Yeah.
So I think the place to start on that is, where is the root cause? all these adverse outcomes are increasing slowly, steadily. And the first step back is very likely to be things such as increased inflammation, increased weight. But why is that? And so that draws our scope back to, I think, two key recognitions, and that these adverse outcomes are very much related to not enough and too much nutrition. So the first one is there's a whole lot of micronutrients that are just even eating a good American diet, the food quality and nutrient density is just not what it used to be. There are farming practices that actually minimize the amount of nutrient that can be extracted from the same broccoli head than it used to be. The soil itself has less mineral content, is less robust in order to provide that nutrient-dense food that we need to build our resilience. And so we also know that the frequencies of these micronutrient insufficiencies is really high, remarkably high. Iron, 18 to 25%, and sometimes higher. By the time people are through, vitamin D, depending on what part of the country you're in. In our study, in our family practice, we realized it was like in the 80% range. And if we're talking if we added in the truly deficient types, then it was like we're at the 90th percentile. So those are just a couple of examples that are key for all the multiple metabolic processes that go on in your body. And yet, even eating these good things cannot seem to get them to the levels that we need. The other piece we realize is that these micronutrients particularly act as cofactors. A cofactor is the way of stimulating a metabolic process in your body for good, for producing proteins, for making neurotransmitters, for creating hormones. And we found so then those deficiencies, and then if you have a gene variant on top of that micronutrient deficiency, then we've got a double whammy going on. Now, we have the capability of understanding those pieces about that individual. We can figure out where their micronutriture lives and how it's responding to pregnancy. We can look at their gene variants and make a great estimation about which parts of their macro and micronutriture need to be addressed to optimize the function of a gene variant that might just not be as effective, or rely on an alternative gene variant that is more effective by optimizing it. Mm-hmm. So there's opportunity in each of these pieces, depending on how we drill down, to come to a much better outcome. So instead of telling a mom, there's nothing we can do, it's like, for you personally, this is your piece that we need to get for you.
And that's the highly personalized aspect of it. That's functional medicine.
Yeah. Mm-hmm. That's right.
Yeah.
And I think societally too, I just want to jump in here. I think societally too, and not to speak in generalities, but we've almost normalized entering pregnancy already depleted and already vulnerable. Mm-hmm. 95% of pregnant women are at risk for at least one nutrient inadequacy or deficiencies. And that's in a high income country. So that's at least one in terms of micronutrient inadequacy or deficiency, let alone the macronutrient imbalance conversation, let alone the diet quality conversation. So it's beyond normalizing that we are kind of accepting this as status quo. I think we also have to consider, back to what Leslie is saying, is how else can we focus on managing a system of complications that first infuses this concept of prevention via the biological of one single individual. And I think that has always been, Beth, that's always been something that I think has turned a lot of people off. It's like, how do you scale personalization? How do you do this? And so I think one of the biggest successes of what we have done is we have in many ways figured out how to continually adapt to the system needs based on where we are. Number one, like I was saying, and in Leslie's bio, we've done this in 4 different states and with 4 different delivery models, meaning that this is not a one-size-fits-all. Thank heavens, because we are also very different and our needs are different. And so I think rather than, pointing our fingers at a system that in many ways is can be considered failing us, I think there's good things about the system, and what we have to do is try to amplify how it functions by providing this parallel care path that ultimately doesn't only just empower the mother, but it empowers the provider too. Because you both being OBGYNs having delivered babies, there's a point where I know, I've seen it in Leslie's face, I've seen it in, statistically in the United States, where we're just seeing these outcomes perpetuate themselves and get worse. And I think I want to bring this, back to that conversation is although there's an indictment of our food system, there's an indictment of Western diet quality, there's an indictment of vulnerability. I think we also have to remember that at the base physiological level, our bodies want to thrive and want to feel well. And so in many ways, we just have to infuse that biochemistry back into the system and the sequence that allows it to function well. And the good news, like what Leslie is saying in our conversation, is that it can happen with some key emphasis on micronutrients and key emphasis on macronutrient balance. But I think it also does include the disruption of the system with somebody like a nutrition professional or a health coach who can amplify the roles that both you and Leslie play too, because you can't do it all by yourself. And I think this is also a larger system conversation.
Yeah, I just had this vision of a plant, like a house plant. That I love house plants, and every once in a while I'll look at my house plant and I'll think like, what's going on with you? You don't look so good. And then you feel the soil and it's like completely dry, and you okay. And then you give it some water, and then it thrives. Like the body is like that. It just needs what it needs. And it can thrive, and it can repair, and it can really get beautiful. And
I think there's just risk. Right. Yeah, and there's just risk amplification here. But there's also, I think it's a blessing and a curse in some ways, because I believe we live in a world that creates nutrient debt long before pregnancy occurs, and pregnancy simply reveals it. But I think we can precede that moment with this preventative conversation, which is really starting in the preconception time period. It's starting the conversation as early as possible once a couple becomes pregnant as well, but I think there's also challenges with that too. I think the running statistic is about 50% of all births remain to be unplanned in the United States. So it's how do you start this conversation earlier, even before the revelation of the pregnancy itself, because that pregnancy can reveal the nutrient debt and the vulnerability that patterned far beyond, because physiological patterns ultimately, they're the canary in the coal mine. They start talking to us way before a diagnosis or a condition shows up. So we've got to be looking. We have to be acute enough and flexible enough to use the system codes, the reimbursement models, the integrations that work already, where we're able to investigate through simple nutrient biomarker labs, utilizing simple standard of care labs to pull out functional medicine composite marker numbers through a simple CBC with auto differential. I mean, it's like really relearning how to see with a new set of eyes, but trying to without ripping apart the system, because there still are good parts to it.
Yeah, and to your point, pregnancy is a canary in the coal mine, because when they come to me for menopause care, if they have a history of hypertension in pregnancy or preeclampsia, gestational diabetes, even postpartum depression, you can see it playing out 20 years later in their perimenopause and menopause. And so my question was, have you seen this playing out in your practice, where women who have undergone the intervention during pregnancy are starting to see potential benefits later in life as they make the perimenopausal, menopausal transition. And I know, Leslie, you had some ideas on that.
Yes, the answer is absolutely. Every hypertensive event in pregnancy gives us less risk of hypertension as we go through our natural aging process. We've also given them empowerment. People make the best changes truly during pregnancy, and you can get a great habit going in those 3 months, 4 months, 5 months, and then it's something that they teach to their child, but it's something that they teach it to their child because it's what they are now doing. They're educated, they're empowered, they feel the difference during pregnancy. Perhaps that's when we reach them, and they continue to feel it, and they continue to think this way. They continue to decide, they recognize that they are empowered to ask the questions. Okay, what is the root cause that's going to carry my health and this built up wonderful sense of well-being that I've not experienced before through the perimenopause and on into menopause? So absolutely, this is a durable feature that's going to reduce risk of later chronic hypertension, later neurocognitive disorders, later menopausal issues. Their experience of menopause, whether that's going to be one that's very difficult for them, or is it one that they have multiple tools in that same systems analysis and empowerment for picking up the things that they can do and letting the other pieces that are not within their purview. They deal with the things that they can do, and they suddenly have a much more a well-being, a sense of well-being through a menopausal experience.
Yeah, and I think it's the toolbox that you've given them.
It's the toolbox.
Yeah.
And they've been able to practice it. And it's the brain. I mean, it's their way of thinking. They don't think of this as, this is a death sentence. This is like, what's the real issue here?
Mm-hmm.
It's not, am I overweight? It's the question is, why am I overweight? And then let's pick apart the pieces that you can get rid of. Let's get rid of the BPA. Let's ditch the phthalates. Mm-hmm. Let's take that glycemic index down. Let's get rid of the air. Let me put an air purifier in. Let me take a look at this. I have a stressful event, and people just do when you can't avoid them. Let me use these techniques for managing my cortisol levels. And I am now empowered to meet our environment as it is, as well as demand for changes in our environment and our food processing.
Yeah. So I'd like to take us a little off our conversation and bring in the men, bring in the fathers. We touched on this before the interview started, and I'd love to hear how this program, when you can catch them before pregnancy, when they're planning pregnancies, how does intervening in the fathers help pregnancy outcomes in the children?
Emily?
Sure, I'd be happy to take this one. I think to ground us first and foremost, and to remind the audience too that ultimately what we're talking about here when we talk about maternal health and paternal health is we're talking about the foundational framework of what is known as developmental programming, or origins of health and disease, which is to say that early life conditions, preconceptive life health status, can impact cardiometabolic risk, neurodevelopment, immune function and resilience, mental health, and ultimately just what is either disease susceptibility or health resilience across the lifespan. And that conversation doesn't only live in the saddle of the mother's health influences, which we know that the mother's health undeniably impacts placental signaling and glucose and lipid exposure and inflammatory tone, and the way that these micronutrients, the status of micronutrients in the fetal transfer, et cetera, fetal growth patterns. But we know that paternal health matters too. And sperm quality specifically, because we're talking about oxidative stress here, DNA fragmentation, et cetera, but sperm quality actually impacts the health of the mother during pregnancy, not just the genetic code that father is passing along to help architect that child. But that sperm quality reflects the nutrition status of the dad, the stress experience that the dad has, the environmental exposures, and really the emotional well-being of that father too, which would fall under the stress and mental health, emotional health, and spiritual well-being. And ultimately what is driving those signals or driving that vulnerability is what is known as epigenetic signaling. And there's just the part of our genes that are, when exposed to certain environmental factors, can be modified to function better, function worse, turn off, turn on. But ultimately, it's a highly modifiable part of our genetic material that actually can create and change the script and the story in and around what is disease vulnerability or health resilience. And so I think it's critical that we talk about this, because paternal health unequivocally influences offspring risk, influences maternal health risk, yet it is rarely addressed. And we have to reframe this conversation, because it's not just about birth outcomes, right? It's just not the event of pregnancy and delivery itself. We are talking about biological programming of health resilience or disease vulnerability. And we have to think about it as shaping the health of future adults. That's as powerful as this time period is. Yes, you are that magical. Yes, you are that powerful. So this conversation needs to happen. And I think, if I remember correctly, there was a study that came out in 2017. It was one of the most cited studies in the world, talking about male infertility and sperm plummeting by 50% since like the 1940s. Is what we're seeing. We're seeing remarkable health, let alone health, which we know impacts the viability of a pregnancy. It impacts it impacts the viability of the mother and the baby's health. And so I think the conversation has to be and centered around is, look at how powerful you are too, Dad. And this conversation has to happen as early in the continuum as possible. But like we were talking about prior to getting on, is that's a hard conversation, because we have 50% of the births in this country are still unplanned. So how do we continue to go upstream of the conversation, but also of reminding the dads that their decisions are as powerful as the mothers in the preconception time period. And ultimately deciding the biological programming of their child. So they matter in a powerful way. And so it's one of the big core tenets of what we've done in the Grow Baby model, which is we focus on the continuum. And I laugh all the time, because we really work in the P's, which all have to do with prevention, which is preconception, pregnancy, postpartum, pediatrics, puberty, perimenopause, and then into menopause. And so and all of those have a preventative story arc to them. Because I think one of the questions that you were asking, in and around the menopause conversation is, you see these women with, move through this cycle in time with better menopause symptoms, or maybe less challenges. They're able to move through the challenges with different tools in their toolkit. I think we have to remember the feed-forward loop, which is to say that hypertensive disorders don't stay in pregnancy. This cluster of hypertensive disorders increases the risk of hypertension in life anywhere from 25 to 50% across that woman's lifetime. Gestational diabetes goes on to increase and confers an increased risk for type 2 diabetes up to 60% in that woman's lifetime. So the decisions that are made and the preventative ripples that happen in pregnancy do transcend across her health span. And so, although we don't have the direct data to show you, what we can say is our statistically significant outcomes that remain durable in our population and our cohort, we can go on to say, because we've had less than 1.5% hypertensive disorder risks, because we've had GDM percentages of less than 1%, et cetera, we can go on and say that our cohort, that these moms that then move in through to their menopausal years are going to have anywhere from they're going to have better vitality, anywhere from 50 to 60% in these key kind of core chronic areas and windows of time.
So I'm going to ask you again. So the outcomes of the pregnancies that follow this model have less than 1% gestational diabetes?
Yes.
And less than 1% hypertensive disorders?
Yes.
And how about preterm labor?
Less than 2%, 1.99%. So we round up to 2%.
Of preterm birth, yeah.
And then
Of preterm birth.
And then how about C-section rates?
Oh, yeah, Leslie.
Yeah, those are, as you know, there are many reasons why people have cesarean sections. They could be geographic, they could be timed, they could be all sorts of things. But if you took all of that out, there's just a lot of personal practice differences, I guess is what I'm trying to allude to. Mm-hmm. But the C-section rate, if it's varies where you are practicing for those sorts of reasons, and it might range from an average of 22, maybe even up to, into the 30% for moderate to low risk pregnancies. But our rate is closer to 14%.
It's wonderful.
So, because you don't have reasons for doing it. I don't have to induce for hypertension. I don't have to induce for blood glucoses that are out of control. I don't have to induce for a baby that's too small for intrauterine growth retardation. I have all these, and our what is our average gestational age at onset of labor? It is more like in the 40-week range. It pushes up. We don't seem to have the preterm labor that others do. We grow term babies with this piece of it.
And I would imagine...
Because I think it is actively anti-inflammatory.
Yes.
We probably think preterm birth has as its system's core inflammation.
Right. And I would also imagine that women in your program are more active, and so there's less malpresentation leading to cephalopelvic disproportion, just bony disproportion. Is that right?
That's right.
Yeah.
Mm-hmm.
Yeah. I'm also curious. I teach mindfulness-based stress reduction, and I'm curious about the mindfulness part of your program. We've talked a lot about nutrition. We've talked a lot about genomics. I'd like to hear about the mindfulness approach that is taken with the group.
Yes. So I think, Leslie, do you want to start, and then I will tag along to what you have to say?
I'll give a little introduction just about how is it that we came to recognizing how powerful this is, and then yes, I'd love you to leap in. And I wanted to use the example the study that comes to mind is asking women, with the idea of trying to reduce the chances of preterm birth and management of stress. And so women are most vulnerable to stress effects on their pregnancy, placental cortisol, et cetera, in that second trimester. And so this study looked at women in their from 15 weeks to, I think it was 24, might have been 22. And they asked those women to put their hands on their tummies and pick their favorite music and listen to that. And then they tested the blood pressure of the placenta in a way. They looked at systolic diastolic ratio in the umbilical cord, the ultrasound, and they found that they were able to positively impact that blood pressure within the womb within 15 minutes of implementing this piece. Mm. So it was very powerful. And then we looked back at a practice that comes as an observational piece of data, powerfully, from 2,000 years ago in China called Taijiao. And they had a peaceful way of managing that included poetry, graceful movement, music, gentle music. And they found that these women who practiced Taijiao had fewer preterm births, statistically significant fewer preterm births. So what we realize is that it's an incredibly nobody can avoid having adverse events, but what we can teach are culturally appropriate means of managing that stress response.
Yeah. Yeah, that
How would you do that, Em?
Oh yeah, Emily, yeah, we have about 3 to 4 minutes left. I'd love to hear from you, Emily.
Sure. I think the other thing, too, is that oftentimes if we don't give somebody a reason why this is happening to them, why they're feeling more anxious, why they're feeling more irritable, why they're feeling more frustrated, it tends to make them feel like they're doing something wrong. And so one of the biggest key things that we do is we also give them measurable information about how their own genetics respond to a stressful event. So part of our screening does include epigenetic screening in and around stress response, where we and you should see the faces of these moms where they have this aha moment, go, that's exactly how it feels like when I'm stressed. And then we say, okay, here's how we cool this pathway off. Here's how we amplify some of these more calming practices that allow this pathway to just really calm down when you're starting to be exposed to a stressful event that you can't control. And so it's giving them more objective data in the reasons why, alongside this like subjective, powerful, emotional, mental, spiritual well-being that allows them to feel like they can take action, which is the basis of behavioral change, right? It's feeling like somebody you're competent enough and have an opportunity and you're motivated enough to shift a behavior, or at least feel like you have control over how something, even if you don't have, you can't take away the insult, how you respond to it. So it's a core part, and I really appreciate you asking that question, Beth, because it's not just the physical nutrition approach. It's also what is driving that emotional well-being that allows the mom to feel resilient in the face of adversity.
Yes, and if it improves placental blood flow, like what more? Mm-hmm. Like that's so powerful. Mm-hmm. Yeah. Mm-hmm. Yeah, amazing. Yeah, and very doable. Who doesn't like to listen to nice music? You just have to find the time. And wow. So is there anything that either one of you want to add or both of you want to add before our time is up?
I have one, and we'll just make it quick because it's a whole discussion. It's a long discussion, and that is the effect of our micro and macronutriture and stress response on our microbiome, and how that influences these adverse outcomes. And that when we understand that effect on the microbiome, how we can optimize it for more successful weight reduction, more for optimization of all these outcomes.
Yes, thank you. Yeah, another conversation. Go ahead, Emily.
No, and what we're seeing, I think, across the board is just not a mystery. It's the result of women entering preconception and pregnancy vulnerable, undernourished, overstressed, overexposed. But the good news here, and the storyline that we want everyone to take away is that we can intervene early, we can support the biology, we can prevent rather than react. And we can improve these outcomes at scale, because really ultimately pregnancy is one of the most powerful preventative opportunities that we have in our lifetime. Mm-hmm. And when we treat it that way, we do see the impact that we know and we dream is possible.
I couldn't agree more. Thank you so much for your time. Mm-hmm. We're going to go now to a commercial, and we'll be back later.
And now, more Rooted in Healing with Dr. Beth Claxton.
Hi, and thank you for coming back. That was an exhilarating interview for me as an obstetrician, to bring like-minded practitioners into the conversation. This interview was about pregnancy. It was about the impacts that we can have in a mother, her pregnancy, the baby, the outcomes of that child. And what I want to say is that it's never too late. It's never too late to change. The body wants to heal. So you may have had your children. You may be menopausal. You may be older, but know that given the right nutrition, the right nutrients, learning how to manage stress in your life, learning how to turn on the healthy genes, the optimal genes, turn off the unhealthy genes, we can still thrive at any age. If you'd like to send this to a loved one, a child, please do that. And if you'd like to tune in and listen to any prior episodes, you're welcome to do that on Mellow Mountain Radio's archives. You've been listening to KAZM 106.5 FM, 780 AM. This is Rooted in Healing. I'm Dr. Beth Claxton. And until next time, find that which makes you feel vibrant, because that is healing and that's going to be your life.